tell me what you think as far as the protocols that are in place. Are we doing enough or do we need to do more?
So first off, I want to say thank you for having me on. Next, what I'd say is, I know this feels scary and it feels kind of intense, but we are way safer now than we were a week ago. So these measures are really going to help us slow the spread of this virus. You can think about the request to stay home and not congregate is like creating a million little quarantines each in our houses. And that gives it time for those who are sick to recover and those who aren't sick not to get infected. So we're in a way better position. Up here in the Bay Area, it's pretty severe lockdown. So we got an order of shelter in place, which means almost all the businesses were shut down. We got an exception called 10B, and that was specifically for our COVID-19 cure program. So we're making an antibody to try to treat patients who have the COVID-19 disease. And so a team of my scientists is coming in shifts to continue to work on that specific project.
I think it's pretty incredible that the show Pandemic, or the docuseries Pandemic, debuted on the 22nd of January, right as the United States was really starting to take this COVID-19 seriously. Tell me your reaction when you saw all this happening.
So when it was getting ready to come out, it was scheduled to come out around flu season, and that made sense. If I was their producers, I would have done that. But I also had warned my team. They were getting excited to be on Netflix, and I was like, guys, there's 10,000 things on Netflix. No one's going to watch this. And then because it came out right around the time of the rise of the coronavirus outbreak, we ended up being on the front page of Netflix internationally for 3 straight weeks, and I think we're trending again. So it was an unexpected deluge of contact. It's obviously terrifying, but it's also the work that we do and we focus on. So we're excited and extremely motivated to apply our technologies to try to create a cure.
Something that did come up in another story that I did, one of the companies that's coming up with a vaccine for COVID-19 was telling us that back in 2015, the WHO tried to warn basically the world that coronavirus, could be a real threat. Maybe we should think about a vaccine. Had we come up with one back in 2015, perhaps we could have used that today. I mean, is this true? And can you talk about that at all?
So there are a number of viruses that have pandemic potential, and we're constantly trying to warn the world about them. The problem back in 2015 is that the vaccine we would have designed then would not have been able to predict and protect against the corona outbreak that happened now. And that's because there are many different species of animals that have many different types of coronavirus, and they all mutate. And so this new virus is something we've never seen before. My group does work on a technology to create broad spectrum vaccines, but we're focusing on influenza. So we have a way of making a vaccine that can protect against future mutant strains. We have not at this point done any work on the coronavirus. And our current efforts are to focus on creating an antibody to treat people that are already sick. One of the problems with the vaccine technologies, and there are multiple good groups that are working on creating a vaccine now for the coronavirus outbreak, but the problem is that you can't give a vaccine to someone who's already sick, because a vaccine takes 6 weeks or more for it to build up the immunity in your body to protect you. And that means you have to give it to healthy people who aren't going to get sick yet. If you're already sick, by the time the vaccine did you any good, you're going to be recovered or die. And so for that reason, we can't just use a vaccine. We also need an antibody therapeutic to treat those that are already sick or at imminent risk of getting sick, like hospital workers.
How close are you to coming up with an antibody that can treat COVID-19?
Yeah, so we were close. Our plans were to be able to deliver a molecule on April 6th to April 13th that week. Then we got this pretty scary announcement from San Francisco and the neighboring areas that everyone needed to shelter in place. Basically, it was shutting down operations. And luckily, we were able to use a 10B exception because this is a critical medical advance. And I offered as voluntary, any of my employees want to come in and keep working on it, and most of them responded and came in. So we're working on shifts right now. We're going to meet that deadline. So by April 6th or April 13th, we're going to have a molecule ready to go. We have partnerships with US AMRID and DARPA from the military that work on expanding these kinds of rapid therapeutic programs, and then a partnership with a company called SwiftScale that potentially make a lot of the medicine very quickly. At that point, we go through a manufacturing process, and we'd start doing a phase 1/2 human trial study, and that would happen this summer. And the results of that study would get us in a position to begin treating a larger population as long as our drug looks good and it's working through compassionate use, and that could be distributed by September. So long story short, if this goes smoothly and the studies look good, we'd be able to have a treatment in place for millions of people by September.
Wow, that's incredible. And I know you're looking alive, I've been watching your Twitter feed. I've been looking all over the YouTube stuff that you've been doing. When you were talking about some of the models, and you've been following the trends that have been happening in South Korea, in China, obviously, in Italy, and you've been saying that you think the United States is trending similar to Italy. Is that right?
So it had been. Yeah, I spent a good deal of time looking at the growth rate of this virus across multiple nations and comparing that to the policies that were enacted. So I and many other epidemiologists and professionals that monitor these things were increasingly concerned by the lack of actions taken in many states in Europe as well as in the United States. That said, last week was a watershed event. We had the World Health Organization announcing this as a global pandemic, and then within a few days, the United States and many other states across Europe started instituting increasingly harsh policies that were absolutely the right choice to lock this thing down. So we are no longer on the same trajectory as Italy experienced. There is still an outbreak, and we're still going to experience doubling for the next few weeks. And that's because this is a silent disease in many subjects, that they don't experience symptoms, but they can be infectious. And that means if it takes them 2 weeks to show symptoms, that we're 2 weeks behind how bad it really is, because the new round of people, the new wave that have been infected, aren't showing any symptoms and haven't propagated to the next group of susceptible individuals next. We are anticipating that over the next 4 to 6 weeks, we are going to run into problems in many hospitals throughout the nation on being able to have enough ICU beds to treat the patients that are coming in. There are many active steps being taken, including expanding temporary ICU facilities into gymnasiums and open areas, potentially taking the National Guard and having built ICUs in tent cities neighboring the hospitals. So the good news is that these harsh measures have bought us some time to be able to implement those policies so that we don't overrun our hospitals.
Do you think that we need to do more, though? Does Southern California need to take the same steps that Northern California is doing? Should the entire United States take the same steps where you're basically in isolation, for 24 hours a day, unless you absolutely have to go out to go to the grocery store or the pharmacy?
So realistically, yes, and that's probably going to take place over the next 2 weeks. The regions of the United States that have not instituted sufficiently harsh policies are going to be punished for it with significant outbreaks and stress to the healthcare facilities. There's two problems to that. One is that people are going to be dying in the waiting room that otherwise could have received treatment, which means the rate of death will go up. And the other problem is that our healthcare workers, who are really carrying out heroic activities on the front line of this thing, are going to become exhausted and increasingly vulnerable to infection. And that's a very dangerous position to be in, because then you lose a population of your healthcare workers and you have even less people handling less professionals there to help, an increasingly large population of the desperate who need their attention. So for that reason, I think we will continue to see increasingly harsh measures, as were observed in Northern California, applied to other regions of the United States. The first ones that are going to need it will be New York and Seattle. But after that, if you've looked at a map, we're having infections all over. So we're going to have a large number of places popping up. And the other good news here is that surveillance has dramatically improved over the last couple of weeks. We have much more people being tested with many more kits. And that means that we're going to have a better handle on where the hot spots are, where we can apply these increasingly harsh measures.
And for people who may not understand why it's important to quarantine or to, get people to stay inside and not have as much contact with others, how can you explain to them why it's so important in a very succinct way? Or can you explain to them briefly why that's important?
Right. So the problem with the new novel coronavirus is that it is much more infectious and it is much more deadly than influenza. And that has been the fundamental problem with containment. The reason it got out of China and the reason it's all over the world right now is that it's very infectious, and you can be infected for a long period of time without showing symptoms, which means that a large number of 80% of people have mild symptoms, and then many people have no symptoms, but they are infecting others during that process. And that means that their bodies are like Trojan horses that are carrying the virus across nation borders, across states, into businesses, and into homes. And that's a problem, because while 80% of people have mild symptoms, the remaining 20% have very severe symptoms. And the death rate is still being evaluated, and it appears different in different areas of the world, but it hovers at around 3%. And that's heavily biased towards the elderly. So people over the age of 80 have about 15% chance of dying when contracting this. And if you think about 3% of the total population of the United States, that's over 6 million people. So they're not going to all be infected at once. But even if a small percentage of a state population gets infected, that's going to overwhelm the hospitals, in which case you don't have space to treat other diseases. You don't have enough doctors and medical staff to even treat those subjects, and the death rate goes up. And that is a significantly disruptive force to medical care nationally.
And one thing I noticed with the news conference this morning with the president was, I believe it was someone from the CDC that came out and gave a warning to young people. You know, a lot of young people that I've spoken to haven't really been worried about this disease. They've still been gathering. They've still been hanging out with their friends. You know, the CDC basically came out and said, you know, there's a small cluster of young people in, I believe it was Italy or France, that had gotten sick and were in the ICU. So is it the case that there's still a lot we don't know about this disease?
Yeah, so there's a couple of things that we still don't know about this. So one is there is a population of people that seem like they don't show symptoms or they show very little symptoms. And we don't fully understand why that's the case. But it also is the case that there are young people in their 20s who could die from this. So it is not safe for anyone. It's also not a death sentence for anyone. And I think it's that variability that is concerning. The other things that we don't understand about this yet and why we should not treat it just like a cold is that when patients recover, they often still have lung damage. So they have this honeycombing from the immune system attacking their lungs. It looks like a kind of like honeycomb pattern on an X-ray. And we don't know how long that takes to recover total lung function. There may also be some immunosuppression that happens in some patients, and we don't know how long that takes to recover. So we don't know the patients who are supposedly cured, how long it takes them to actually return to full healthy function. And just as a precaution, in case that's longer than we think, we should definitely encourage people to not get sick. The other reason why I would implore people in their 20s and 30s, even if they think that they're at low risk, to not go out and ignore this and party, is that they are putting their families at risk. Because eventually they're going to go home. They're going to talk to their grandmother or their grandfather, and they could put or someone who's immunocompromised. And so even though they survive, they're putting loved ones at risk. So for that reason, we just implore everyone to stay home and minimize contact through social distancing measures.
And one thing somebody wanted me to ask, you know, as far as pets go, a lot of us here all have pets. From everything we've known so far, they aren't at risk to transferring the disease or transmitting it to other people. You know, why is it that pets don't get it, and why is it that they're not really transmitting it to humans?
Sure. So our basic assumption with most viruses is that they usually have relatively limited number of species that they can infect. And that's because the virus has to go in and engage like a lock and key with specific cell types on a specific species in order to infect that cell. Now, this virus we know is zoonotic, which means that it could transfer from one species to another. And it probably came from bats, may have gone through another species in between, but it infects humans. There have been some reports, and I've been reviewing this data and it appears mixed, but some reports suggest that dogs are able to become infected and they have low-level shedding of virus or viremia. What's not established is, are dogs able to infect each other, or are they able to infect their owners? I would say in the meantime, until the data's out, in an abundance of caution, I would urge your dog owners not to let their dogs lick and interact with other dogs for the time being, just to avoid that as a possible mechanism of transmission of getting this virus into your house. And I'll just be clear, at this point, we have not established that there's dog to dog or dog to human transmission. This is just a precaution until those studies have been characterized further.
So where do we go from here? You know, having all this information that continuously changes, and it's almost hard not to get overwhelmed by all the stuff that's out there. I mean, where do we go from here? What advice do you have for people?
Sure. So what I would say is that you should be informed, you should be prepared, but you should not have to be scared. Biotechnology is better than it has ever been before. The world has taken the absolutely correct set of strong political actions to reduce the spread of this virus, and new medicine is coming. So in the meantime, follow the social distancing measures. There's lots of great things you can do with your time. You could read books, you can watch some shows, you can interact through social media to find ways to interact with the world and keep doing what you're doing without having to contact people a lot, as we just play a waiting game here to limit the spread of the virus. Now, we do think that we do need a medicine. Without effective medicines, this thing will just continue to spread throughout the population, and we have some concerns that it may become seasonal, that if enough people around the world get infected, the new mutant versions will appear, like the flu, and we'll have an annual problem. To address that, there are three kinds of medicine. First, there are antivirals and antimalarials, these old drugs that are being repurposed and checked against the novel virus. These include Kaletra, which is an HIV cocktail. This includes remdesivir, which is a Ebola drug. And this also includes chloroquine, which is an anti-malaria. These are all being evaluated, and we're going to have results in April telling us whether these are helpful for the disease. That's coming up soon. And if any of those work decently well, large numbers of people are going to start using it. Chloroquine is already being utilized in China and South Korea. I think Kaletra is also in some of those protocols. So the next step are vaccines, but vaccines take a long time to develop. And the reason is that even though companies like Moderna, there's a group in Israel, the NIH, Chinese, and a number of other groups have created vaccines very rapidly here. It was great. Vaccine studies are slow because when you give someone a vaccine, you're making their immune system take many weeks to develop the antibodies against the virus before that person would have protection. And these are new vaccines, so we want to make sure that those vaccines aren't accidentally hurting the person in the process or making them more vulnerable to infection. Those studies are slow. You can't give them to patients. You have to give them to very large numbers of healthy people and wait to see their response, whether they're protected later. And that means that realistically, we're not going to get an effective vaccine until 18 months, maybe 15 months from now. So we're looking at 2022. The space in between is what my company's working on, and there are other groups working on this as well. So what we're doing is creating an antibody therapeutic. The way we're doing this is we found these antibodies that were against SARS from 2002. 18 years ago, we found this population of 5 really good neutralizing antibodies that could block SARS. If SARS ever came back, these would be great medicines against SARS. We are then using some of our proprietary technologies at Distributed Bio to tweak those antibodies to now recognize the new coronavirus. And the power of that technique is that we are able to hitchhike on 2 years of research on each one of those antibodies to take those drugs, adapt them to the new threat, and release them very quickly. So our molecules are going to be ready in the beginning of April. We're partnering with the US military, US AMRID, and DARPA. We're partnering with Charles River Labs, a 16,000 person company that is professionals at doing safety profiling of new medicines. And we're partnering with a company called SwiftScale that can grow a lot of our medicine very quickly. And we're setting ourselves up to do human trials, safety and efficacy. So is it safe and does it work in summer? So an antibody we can give directly to patients. So within 5 to 10 days, we immediately know, did it protect them? So there are these very fast studies, and everybody who received the medicine is a data point that's useful. Unlike a vaccine where you have to give it to 10 times as many people as are going to get sick. And that means is if that looks good, we're going to be the fastest way to create a new medicine, and that could be out by September. And that's something that we could work with SwiftScale on to create hundreds of thousands or millions of doses. So that still means we're hunkering down until September unless we get lucky and one of those, the Kaletra, the chloroquine, or the remdesivir works for us. One way or the other, we have waves of medicines that are coming. There are many groups working on this, and biotechnology has never been better than it is now. So we will have the medicines in place, and for now, it's just a waiting game.
So 2 last questions I have. One, based on the protocols we're putting into place, based on the numbers you're seeing, do you have a prediction on how many people in the United States will get sick and how many will pass away?
So there are ranges, and it depends a little bit on the rate of spread. On the pessimistic end, there are studies from Harvard and elsewhere that indicate that this thing could end up infecting most humans, so 40 to 70% of all humans globally. And that could happen. If that happened in the United States, then that means there's a lot of death. And that's the reason why the president, the White House, the CDC, and the states have acted so aggressively, because you could be looking at 6 million dead Americans. They want to avoid that. More realistically, with these measures in place and with the appropriate delays, we could be looking at hundreds of thousands of infected individuals within the next few weeks. I estimate California will have 40 to 50,000 by mid-April, and those numbers could be 10 times that by May. But I will remind you that we watched China go through an exponential growth phase, and then their social distancing measures managed to slow the growth. They kept their numbers under 100,000. So it's not inevitable that you have everybody get infected. With the right social measures in place and the right treatment, we can protect our population. So that's sort of the range of where we're working with. I think it's unlikely we're going to have less than 500,000 people infected in the United States, just based on the growth at this point. It's too late to avoid that level of growth. But we could avoid the scenario where we have 200 million infected. And I think that's still definitely something we could avoid at this point.
And based on your research and based on your models, do you have any idea or prediction on when we can go back to life as normal, the new normal, whatever that ends up being? Are we talking next year? Are we talking next summer? Are we talking this summer? What are we talking?
Yeah, that's the $1 million question. So right now, politicians are putting stopgap measures in place to buy them a little time to make decisions going forward. So I think what we're looking at right now is the next 2 to 3 months, we're continuing to see a lot of potential growth. And these social distancing measures need to be applied. I think everyone should anticipate maintaining these social distancing measures for at least the next 2 to 3 months. The appearance of a good small molecule drug could change that, because then this becomes a less dangerous disease. So we're kind of all crossing our fingers that we get some good results on one of those 3 drugs in April. I should also mention that the UK is running a 10,000 person study on chloroquine right now. The remdesivir is being run by Gilead in China and the United States. And I'm less familiar with where Kyletra is, but that's being evaluated as well. If we don't get a magic bullet out of April, then these measures will likely continue to some degree out until September, when I will be able to deliver my medicine, and there's other groups that are also producing rapid medicines that could be effective during that period. Once we have good medicines in place, this becomes much less of a problem, because you can treat people, they'll experience less symptoms, the death rate will go down, and it'll be more safe to contemplate herd immunity. Right now, we don't want herd immunity because the risk to the population is just too high, and we're also seeing some troubling cases of individuals that appear to have cleared, but then they appear infected again, or they never cleared the virus in the first place. And so for those reasons, we need a medicine at this point. If I were to guess, you're talking about 2 to 3 months of these social distancing measures in place, and then we reevaluate at that point whether we need to continue with them. At a certain point, people need to go back to work, because this is going to have a negative impact on the economy. And so I think the ingenuity of Americans is going to be such that we're going to find creative ways to solve and route around this, use advances in the internet and appropriate distancing measures at workplaces to be able to resume the economy. We should be realistic that that may not be until September or October or November.
Wow. Anything else you want to say or add that I'm not asking you that you think it's important for the public to know?
I just want to let you know that we are not stopping. That my group and many other exceptional groups in biotechnology space are working tirelessly to create a medicine. We have never been faster than we are now. We were faster with Ebola than we were with HIV. We were faster with HIV than we were with measles. You are all benefiting, and all of our family members and our loved ones are benefiting from an arms race in optimization of biotechnology. Really in a golden age here, and we're going to be able to make these medicines, and we're going to beat this thing. Because the virus is dumb and we are smart.
Okay, thank you so much. I appreciate your time.
Thanks, Jacob.